Welcome to the deep dive. We're tackling facial rejuvenation today, focusing on the non-operative techniques, the ones you'll need to know like the back of your hand for your exams.
It's a rapidly growing area, non-operative approaches. Patients want less downtime, but still want to look their best.
Absolutely. So let's start with the basics. The why. Why does the face age? We've got two primary culprits here, actinic damage, and then just good old-fashioned chronologic aging.
Sun damage is the big one. Actinic damage. It's like the sun slowly chipping away at the structural integrity of your skin, you know?
Yep.
It messes with the elastin, the collagen. And those are the proteins that keep skin firm, elastic. And without them, you get fine lines, wrinkles, sagging, uneven pigmentation, and if it gets really bad, skin cancer.
We use the Glogau classification to figure out how bad the sun damage is. That helps us decide what to do about it.
Right. But it's not always just the sun's fault. We've got intrinsic aging, too. Chronologic aging happens to everyone. It's just the dermis thins out over time, collagen production slows down, gravity starts to win. So you get wrinkles, sagging, volume loss. And obviously, if you've got sun damage on top of that, it's going to be worse.
And for that type of aging, the Fitzpatrick classification helps us out. We look at the wrinkles around the eyes, the mouth, see how severe they are. Gives us a roadmap for treatment.
Now, before we get into the nitty-gritty, the treatments themselves, our sources are really hammering this home. You have got to thoroughly evaluate your patient, understand their anatomy, their skin type, what they're hoping to achieve.
Absolutely. So we're looking at static versus dynamic wrinkles. How thick is their skin? What's their Fitzpatrick skin type? How much sun damage have they got? That's where the Glogau classification comes in again.
And you got to be straight with them about expectations. Non-operative stuff can make you look younger, sure, but it's not a facelift. It won't be as dramatic or last as long.
Okay, so we've laid the groundwork. Now let's jump into the treatments. Let's start with lasers. Everyone loves lasers.
Lasers. Controlled thermal damage. That's the key. We're using specific wavelengths of light, to cause a very specific injury, which then kicks off the body's healing response, stimulates collagen remodeling, tightens things up.
We can split those lasers into two main groups, ablative and non-ablative.
Ablative. That's like taking a layer of skin off, vaporizing it. The CO2 laser is a good example. It targets water in the skin, leads to ablation, dermal damage. The endpoint you're looking for is a pale yellow color. That means you've reached the mid-reticular dermis.
And that depth, that's crucial.
You're right.
Too shallow, you won't get the results. Too deep, you risk scarring.
Exactly. And the CO2 laser can cause hypopigmentation, especially in lighter skin types, so you got to watch your energy levels. Cooling times. Really carefully. Other things to watch out for. Erythema, hyperpigmentation, melia. Sometimes it can make acne worse.
Another ablative option, erbium.YAG laser.
Erbium.YAG. Shorter wavelength, so less thermal diffusion, heals faster than CO2, but that also means less dramatic results. That's a trade-off you'll see a lot with lasers.
Fractional resurfacing, that's another technique. Designed to minimize downtime. How does that work?
Tiny little zones of damage, surrounded by healthy tissue, microscopic thermal zones. It heals faster, but you usually need multiple treatments to get where you want to be.
Okay, now let's talk non-ablative lasers. Starting with the ND.YAG, a real workhorse.
Yeah. ND.YAG, 1064 nanometers, gets deep into the dermis, stimulates collagen. Doesn't vaporize the top layer, though. Works on all skin types, but again, less dramatic results than ablative lasers. Gotta manage those expectations.
There's also the 1320 nanometer ND.YAG, targets water, but you need to use a cooling agent to protect the epidermis.
No. IPL. Intense pulsed light. People lump it in with lasers. But it's not actually a laser. It uses a broad spectrum of light to target different chromophores in the skin. Chromophores are like, targets for the light. So IPL can help with hyperpigmentation, redness, even skin texture. But you'll usually need multiple treatments.
All right, let's move away from lasers and talk about mechanical resurfacing, starting with dermabrasion.
Dermabrasion. We're using a rotating device to remove the top layers of skin, kind of like sanding it down. Stimulates collagen, reveals fresh skin underneath, good for fine wrinkles, acne scars, even a little bit of skin tightening.
But depth control is super important here.
Right.
You got it. You're looking for pinpoint bleeding. That means you've hit the papillary dermis. Too deep, you'll get scarring. Too shallow, not enough improvement.
And our sources say the surgeon's skill really matters here. Experience makes a big difference with dermabrasion.
Now for something a little less intense, microdermabrasion. Think of it as dermabrasion light. Uses tiny particles and suction to exfoliate the skin. So microdermabrasion, good for improving skin texture, mild acne scarring, some pigmentation issues.
It's not as consistent as dermabrasion for wrinkles, but there's basically no downtime. Patients can go right back to their normal routines.
So we've covered lasers, mechanical resurfacing. What other non-ablative skin tightening options do we have?
Thermage uses radio frequency energy, delivers it to the deeper layers of the skin, heats the tissue, stimulates collagen production.
And it's got a cooling mechanism.
Yeah.
To protect the surface of the skin from burns.
Right. It can tighten things up a bit, mild laxity, especially on the face and neck, but it's not going to be as dramatic as a facelift or even ablative laser resurfacing. And there's a small risk of fat atrophy, but it's rare.
Ultherapy is another one. Uses focused ultrasound.
Focused ultrasound energy, stimulates collagen, can get down to the SMAS, that's the muscular layer under the skin.
Yeah.
It's even FDA approved for treating contour deformities in the head and neck, submental area.
So, both thermage and ultherapy can tighten skin without surgery, but the results are subtler.
Yeah, and that's important to tell your patients. These treatments are best for people who want some improvement without the downtime of surgery, but they gotta be okay with the fact that the results might not be huge.
Let's move on to chemical peels, another classic for non-operative facial rejuvenation.
Chemical peels, controlled injury to the skin, that's the idea. We're forcing the skin to regenerate. Helps with fine lines, wrinkles, pigmentation problems, acne scars, lots of stuff.
We can group them by how deep they go. Superficial, medium depth, deep. Superficial peels, just target the epidermis. Good for mild pigmentation, texture, minimizing fine lines.
Medium depth, gets down to the epidermis, so it's better for deeper wrinkles. Acne scars, more noticeable pigmentation problem.
And deep peels, they penetrate all the way to the lower dermis, reserved for the tough cases, severe wrinkles, sun damage, really bad pigmentation, longest downtime.
What determines the depth of a peel? Lots of things. The type of acid, the concentration, how you prep the skin, application technique, how long you leave it on.
All right, let's talk about some specific peeling agents. Alpha hydroxy acids, AHAs.
AHAs. You see them in over-the-counter stuff all the time. But at higher concentrations, they're used for peels. They break down the bonds between skin cells, promote exfoliation. New skin comes to the surface. Glycolic acid, lactic acid, those are common AHAs.
Gessner's solution, that's a popular one. Resorcinol, salicylic acid, lactic acid, all mixed together.
Gessner's can be a superficial peel on its own, or we can use it to prep the skin before a deeper peel, like a TCA peel. The more coats you apply, the deeper it goes, and the longer it takes to heal.
Salicylic acid, that's a beta-hydroxy acid, a BHA.
Yeah.
It's good because it dissolves in oil, so it can get into oily skin. Great for acne.
Salicylic acid also has anti-inflammatory properties, and it can act as a bit of an anesthetic, so it's good for sensitive skin.
For a quick superficial peel, you can actually use dry ice.
Dry ice, yeah. You apply it with an alcohol-acetone mixture. The longer you leave it on, the deeper it goes.
Perchloroacetic acid, TCA, that's a workhorse for medium-depth peels.
TCA. Powerful stuff. Different concentrations for different depths. Usually takes a few days for the skin to peel off, and then you see the new skin underneath. We often pre-treat with retinoids, like tretinoin.
Yeah. The tretinoin helps thin out that outer layer of skin, so the TCA can penetrate more evenly and heals faster.
Now for the heavy hitter, the phenol peel. Deepest peel you can get. Amazing for wrinkles, sun damage, pigmentation problems. But it's got a long downtime, and there are risks.
One thing our sources emphasize, you got to monitor the patient's heart during a phenol peel.
Phenol can cause heart arrhythmias, so yeah, cardiac monitoring is essential, especially if the patient's got a history of heart problems.
Two common formulas, Baker-Gordon and Headers. They're slightly different ingredients, different potential side effects.
Yeah, no matter what kind of keel you're doing, there's always a risk of complications. Infection, redness that hangs around, acne flare-ups, scarring, pigmentation changes.
So, careful patient selection, proper pre-treatment, meticulous post-peel care, all essential for minimizing those risks.
All right, moving on to the big one, botulinum toxin. Botox. Everyone knows Botox.
It's revolutionized wrinkle treatment.
Right.
Temporarily paralyzes the muscles, smooths out the skin. You look more relaxed, more youthful.
7 different types of botulinum toxin, but only type A and type B are used for aesthetics.
And even within type A, you've got different brands, Botox, Dysport, Xeomin. Each one is a little different.
And you gotta remember, the units are not interchangeable between brands. You can't just swap them out willy-nilly. Each one has its own potency, dosage guidelines.
And to get good results with botulinum toxin, you need to know your anatomy and you need to have a good injection technique.
Absolutely. You got to know which muscles to target, where to put the needle, how much to inject. You want to smooth out wrinkles, but you don't want to freeze the face. You want to preserve natural expression.
Let's go over some specific areas and what to watch out for, starting with the globular complex, the 11s.
The corrugator supercilii, procerus, orbicularis oculi. Those are the muscles that cause those frown lines. We're injecting into the corrugator. And the procerus, staying well above the orbital rim. Don't want to drop the eyelid.
Horizontal forehead lines, caused by the frontalis muscle.
You can get a brow lift by injecting the frontalis, but don't go too low. You don't want to give them Spock brows.
Crow's feet, those lines around the eyes. Lateral orbicularis oculi.
Before you touch those crow's feet, you got to check for lower eyelid laxity. If they've already got some drooping, injecting there could make it worse.
Bunny lines, little wrinkles on the sides of the nose when you smile. Nassalis and procerus muscles.
Inject superficially here to avoid bruising.
Perioral wrinkles. The vertical lines above the lip. Orbicularis oris.
You can get a little lip enhancement by injecting the orbicularis oris, but stay away from the corners of the mouth. Don't want them drooling.
Dimpled chin. Emptalis muscle.
Smooth out the chin. Make the profile more balanced. Avoid the depressor labia, though. You don't want to mess with their lower lip movement.
Marionette lines. Those lines that go down from the corners of the mouth. Depressor anguli oris.
Soften those lines. Lift the corners of the mouth.
Platysmal bands. The vertical cords in the neck. Platysma muscle.
Botulinum toxin can work for those, especially if they have good skin elasticity. But it won't get rid of excess skin or fat, so it's not a replacement for surgery.
And that brings us to soft tissue fillers.
Fillers. Plump up the skin, fill in wrinkles, restore lost volume. You look fuller, more youthful.
The perfect filler would be safe, non-toxic, non-allergenic, easy to use, no downtime, predictable results, reversible. And it would age gracefully with the patient. But that filler doesn't exist yet.
We've got 4 main classes: autologous, biologic, synthetic, and off-label.
Autologous. That means it comes from the patient's own body, like
Yep.
fat.
Biologic, usually a naturally occurring substance, collagen, hyaluronic acid, stuff like that.
Synthetic. Man-made. Calcium hydroxylapatite.
Yeah.
Polylactic acid.
Off-label, approved for something else, but we use it for filling.
Be careful with those off-label fillers. There can be legal issues. Make sure you're up to date on the guidelines.
So, let's talk specifics, starting with autologous fat.
Fat grafting. It's a good option for restoring volume, contouring the face. Natural-looking results can last a long time. But it's technique sensitive, so the results depend on the surgeon's skill.
You got to harvest the fat carefully, place it just right, make sure there's good contact between the fat and the surrounding tissue so it integrates well and survives.
Hyaluronic acid fillers, HA fillers, they're everywhere these days.
HA, it's a natural part of your skin, keeps it hydrated, plump. We use a synthetic version, cross-linked, makes it into a gel.
Lots of different HA fillers out there. Restylane, Juvederm, Belotero, they all have slightly different properties.
And our sources do a good job of breaking down the differences, which is helpful for your exams and for when you're actually practicing.
We inject them with a fine needle, can treat all sorts of things. Fine lines, deeper folds, volume loss.
For lips, don't overdo it. Keep it subtle. You can use botulinum toxin too to relax the muscles around the mouth, enhance the results.
Nasolabial folds. Layering different HA fillers can work well, and sometimes we tape the folds afterward to prevent the filler from migrating.
Calcium hydroxylapatite, KH.
Kawisha. It's biocompatible. We use it for bone grafting too. Stimulates collagen production, gives you immediate volume, and it lasts.
Good for deeper wrinkles, folds, cheek augmentation, jawline contouring. But there's a chance you could get lumps or bumps, so your injection technique has to be on point.
Polylactic acid, PLLA.
PLLA, it's synthetic. Gradually stimulates collagen, so you get improvement over time. Volume, wrinkle reduction, good for deeper wrinkles. Folds, restoring volume in the cheeks. Temples.
Massage the area after you inject it to spread it out evenly, prevent lumps.
And you'll usually need a few sessions to get the full effect.
Lastly, polymethyl methacrylate, PMMA.
PMMA, this one's permanent. Your body doesn't break it down. Little microspheres of PMMA, suspended in a collagen gel.
Our sources say, don't use it for superficial wrinkles or thin skin. You might be able to see those microspheres. Better for deeper stuff, like nasolabial folds, deep marionette lines.
You got to be really precise with your injections. You don't want lumps. And be aware of granulomas. little bumps that can form under the skin.
So many different fillers. Choosing the right one, it's an art. You got to think about the patient, what they need, what they're hoping to achieve.
Every filler is unique. Different characteristics, advantages, disadvantages. You got to know all that to make the right call for your exams and for your patients. Back for more. Good. Let's dive into post-treatment care, patient selection, and those pesky complications that can pop up with non-operative facial rejuvenation.
Yeah. Got to know how to manage those patients. After their procedures, what could go wrong, how to handle it, critical stuff.
Okay, so ablative laser resurfacing post-op care. This is where they love to hit you with exam questions because it's so important to get it right if you want them to heal well and minimize those complications.
Most wound healing. Big emphasis on that in our sources.
Absolutely.
Yeah.
Got to keep that treated area moist. Lipid-based ointments help that new skin grow back, re-epithelialization, and it helps prevent scarring, like creating the perfect little environment for the skin to do its thing.
Prophylactic antivirals too. Acyclovir. Prevent those herpes simplex outbreaks.
Herpes can really mess things up. Delays healing, increases the risk of scarring, especially if they've got a history of cold sores. So yeah, antivirals are a must.
Antibiotics too. Prevent bacterial infections.
And sometimes antifungals. Got to cover all our bases.
Steroids. For inflammation, swelling.
Yeah, steroids can help with the discomfort, make the recovery smoother.
And if the patient's worried about pigmentation changes, hydroquinone, kojic acid, and of course, religious sun protection.
Sun protection, absolutely crucial after any resurfacing procedure. That new skin, it's super sensitive to UV damage.
Okay, let's talk about choosing the right procedure for the right patient. That's where your clinical judgment comes in. Knowing all these different treatment options, inside and out.
Right. It's not one size fits all. Got to tailor it to the individual. And the sources really stress that. Thorough pre-treatment assessment, that's key.
So we're looking at their skin type, Fitzpatrick. How bad are their wrinkles, Gallagher scale, any underlying medical conditions, and probably most important, what are their goals? What are they expecting to get out of this?
And like we talked about before, you got to level with them about the limitations. Non-operative treatments, they can definitely help, but they're not surgery. They won't get the same dramatic results, and they won't last as long.
Their lifestyle matters too. How much downtime can they handle? Some procedures, like ablative laser resurfacing, that's a lot of downtime. Others, like Botox, not so much.
Let's walk through a few scenarios, help you picture it. So say you've got a patient, fine lines, wrinkles, mostly around the eyes, mouth.
Okay, so first thought, botulinum toxin. Relax those muscles that are causing the wrinkles.
Could also use some HA fillers, plump up the skin, soften those lines.
And if they're worried about skin texture, pigmentation, maybe some chemical peels or IPL treatments.
Now, what if it's deeper wrinkles, volume loss?
Deeper wrinkles, you're probably going to need a combination. Botox and fillers.
And for volume loss, fat grafting, or a volumizing filler, KH, PLLA. You can often use these things together and get the best of both worlds.
Patient comes in with sun damage, rough skin texture. What then?
Resurfacing. Something like ablative laser resurfacing or dermabrasion. Get rid of that damaged top layer. Stimulate collagen. They'll end up with a smoother, more youthful complexion.
But you got to make sure they understand the downtime. It's not insignificant.
Okay, now let's talk about what could go wrong. Complications. Every procedure has risks. And non-operative facial rejuvenation, it's no different. The sources go into detail about all the potential pitfalls.
You got to know these complications, how to prevent them, how to manage them. Essential knowledge for any plastic surgery resident.
Okay, laser treatments, pigmentation changes, that's a big one.
Hyperpigmentation. Hypopigmentation.
Usually temporary, but sometimes it can be permanent, especially if the laser settings aren't right, or if the patient's prone to pigmentation problems. Scarring, another risk, especially with ablative lasers.
Happens if the settings are too aggressive, or if the patient doesn't heal well, or if the post-treatment care isn't meticulous.
Infection.
Not as common, but it can happen.
Yeah.
If they don't keep the area clean, don't follow instructions.
Okay. Botulinum toxin. What can go wrong there?
Bruising happens all the time.
Those little needle sticks. You're bound to hit a blood vessel
Like
sometimes.
small needle. Ice. Tell them to avoid blood thinners beforehand. That all helps.
Asymmetry.
If you don't inject evenly on both sides. So yeah,
Yeah.
got to know your anatomy. Be meticulous with your technique.
Eyelid drooping. Bitosis.
When the toxin spreads, gets into the muscles that control the eyelid. So be careful where you inject. Stay away from those eyelid muscles.
Fillers, what about those?
Swelling. Happens with pretty much every filler.
Normal, part of the healing process.
No.
Nice. Keep the head elevated. That helps.
Bruising. Same as with Botox.
Lumps and bumps.
When the filler isn't distributed evenly, or it migrates.
Yeah.
Or their body just doesn't like it.
Effect rare if you're using sterile technique. And they keep the injection site clean.
Vascular occlusion.
Yeah. That's the one you really don't want to see. When you accidentally inject filler into a blood vessel, blocks the blood flow.
Can cause tissue damage, even necrosis.
Gotta know your facial vascular anatomy.
Yeah.
Avoid those areas where the blood vessels are right there at the surface. And if you think you've caused a vascular occlusion, you gotta act fast. Dissolve that filler. Get the blood flowing again.
So, non-operative facial rejuvenation. Generally safe, if you know what you're doing, but these complications, they're a reminder. You got to be careful. Meticulous technique. Know your anatomy. Know what can go wrong.
Couldn't have said it better myself. Keep that in mind for your exams and for when you're taking care of real patients.
Welcome back. Let's get practical.
Yeah.
Botulinum toxin, fillers, the bread and butter.
This is where the rubber meets the road. It's one thing to know the theory, but to actually master these injections takes practice, lots of it. You got to have that three-dimensional understanding of the face. You're always refining your technique.
Our sources, they break it down. Specific injection techniques for different parts of the face. Let's start with botulinum toxin.
The goal is targeted relaxation. You want to soften those wrinkles, but you know, you don't want to freeze the face. It's got to look natural.
Right, and our sources really hit this hard. Dilution, dosage, make sure it's right for the specific product you're using.
Absolutely. Units are not interchangeable. Can't stress that enough. Use the wrong dose. You'll either undercorrect or overcorrect, and neither of those makes the patient happy.
Small needle. Inject slowly, carefully. Minimize discomfort. Bruising.
Needle placement. It's everything. You got to know those muscles, like the back of your hand.
Yeah.
And don't want to be hitting any blood vessels.
Glabellar complex, the 11s. What's the approach?
Corrugator supercilii. Procerus. Stay above that orbital rim. Otherwise, droopy eyelid. Not good.
Crow's feet. Anything specific we need to watch out for there?
Lower eyelid laxity. Got to check that before you do anything. If they're already got some drooping, injecting there will make it worse.
And our sources. They go through all the other areas, too. Forehead, bunny lines, perioral wrinkles, chin, even the platysmal bands.
Each area, it's its own little world, different landmarks, different techniques, but the goal is always the same. Get the best result with the fewest complications.
Okay. Shifting gears, soft tissue fillers. Different ballgame compared to botulinum toxin.
Oh, yeah. Fillers, you're sculpting, you're shaping. It's more than just knowing where the muscles are. You got to have an eye for it. Understand how these fillers behave in different tissues.
Choosing the right filler.
For
The job,
right.
that's crucial.
Viscosity, longevity, lifting capacity, they're all different. Got to think about where you're injecting, how deep the wrinkle is, how much correction you need.
And just like with botulinum toxin, technique matters.
You want it to look natural. You don't want complications.
Linear threading, fanning, cross-hatching, different techniques for different situations.
Nasolabial folds. Layering usually works best. Different depth creates a smooth, natural look.
Lips, easy does it. Don't overfill.
Yeah, nobody wants duck lips.
Our sources cover all the other areas, too.
Mm-hmm.
Cheeks, temples, jawline, chin.
Small needle. Inject slowly. Massage afterwards. Spread that filler out nice and even. Prevent those lumps.
Now, let's step back a bit. Bigger picture. Advanced concepts. Stuff you'll need to know as you progress in your training, in your practice.
Combination therapies, that's a big one. Using multiple treatments together to get a better result.
Like
Yeah.
botulinum toxin and fillers. Get rid of the wrinkles and restore volume at the same time.
Ultrasound guidance, that's becoming more and more common for fillers.
Ultrasound, so you can actually see what you're doing under the skin. Make sure that filler goes exactly where it needs to go.
Less risk of complications, especially vascular occlusion.
Biostimulatory fillers. Those are interesting.
Immediate volume, and they stimulate collagen growth over time. Longer lasting results.
This field, it's constantly changing. New techniques, new products. You got to stay on top of it.
Couldn't agree more. So, there you have it. Non-operative facial rejuvenation. We've covered a lot of ground. From the science, to the techniques, to the potential complications. We hope this deep dive has given you what you need to ace your exams and to provide excellent care to your patients.
Remember, never stop learning. Always refine your technique. And most importantly, always put your patients first. That's what it's all about.